Good afternoon, everybody. Many thanks to organizers, especially Dr. Munitic, for an invitation to this prestigious meeting. As you heard, I am a clinician from Department of Neurology, so my perspective will be more from a clinical point of view, and this is the title of my presentation. I have got some contacts with pharmaceutical companies as a clinician. So, a biomarker is a signal from a fluid which tells us something about pathogenesis or pathology of the disease. But at the same time, it has to be reliable, easy to perform, and inexpensive. That immediately means that it is something which is translated from basic science to clinic. And neurodegeneration biomarkers are mainly used in the diagnosis of neurodegenerative diseases, the prototype Alzheimer's disease, but some other too. But they can be also used in neuroinflammatory disorder. For example, to tell us something about prognosis of the disease, response to treatment, and also to give us some pathological insights into these diseases. I will mainly touch multiple sclerosis because this is my field of expertise. I will also briefly touch some infectious diseases and some other autoimmune disorders. So MS is a prototype of disease where biomarkers are extremely important because it has got this beginning, relapsing, remitting, with later progression, which we want to suppress. Many disease-modifying treatments are now available. This is just to give you a perspective. If 20 years ago we have 300 patients on DMTs, only 2 DMTs, now we have nearly 2,000 patients on 10 different medications. And these drugs have different side effect profiles, different efficacy, different tolerability. So which drug to use is also dependent on biomarker results. So if we classically see the pathogenesis of multiple sclerosis, we know that this is an autoimmune inflammation, starts at periphery, disrupts blood-brain barrier, and causes inflammation, demyelination, resolution of inflammation. But at the same time, degenerative processes start in multiple sclerosis, which can be measured with the biomarkers. For example, axonal loss, acute or chronic, and neurofilament light chain, for example, is a biomarker. Microglial activation with chitinase as its marker. Astrocytosis with scar formation, GFAP. Amyloidosis, not shown here. And also neuroregeneration, GAP43, for example. And these biomarkers can be measured in cerebrospinal fluid and also with sophisticated technology in plasma. Neurofilaments are part of axonal cytoskeleton. There are 3 different chains, high, medium, and low. So this is
not us.
And they can be released into parenchyma and fluids upon axonal loss of any type. And they can be measured either in CSF, but also with technologies such as Simoa in blood. Now, very high levels, for example, are observed in Creutzfeldt-Jakob disease or ALS. But as far as multiple sclerosis is concerned, neurofilament light chain, which is the most studied biomarker, give us information about early clinical course. They predict relapses, MRI activity, gadolinium-enhancing lesion. This is a study we did a couple of years ago, showing we included 150 patients, followed them for 4 years, and it was shown that neurofilament light chain predicted relapses in the coming years. Okay. Diffuse microglial activation is something which is now known that is associated with disability progression in multiple sclerosis. And therefore, chitinase as its marker was expected to be more correlated to disability progression. And indeed, many studies show that. For example, our study again, chitinase predicted disability progression at 4 years, but not relapses. We have got a type of multiple sclerosis, primary progressive multiple sclerosis, which has got poor outcome because it progresses from the beginning. It is also poorly treatable disease. Only one medication is available, but still we would want to know what patients, who of our patients will progress, who will be proper candidates for treatment. This is a study we did a couple of years ago. There are some more samples. And we showed that neurofilament light chain did not predict progression in progressive multiple sclerosis, but chitinase did. And there was a nice correlation between chitinase level and disease duration. So see, early on, some patients have low chitinase and some high chitinase levels. Perhaps these are the best candidates for ocrelizumab treatment. Astrocytes have many functions in the brain, as you know, even in multiple sclerosis, damaging and neuroprotective. GFAP is primarily seen in astrocyte enfids that are closely connected to blood. So it was expected because they are associated, astrogliosis is associated with worsening of disease. The GFAP will be more associated with disability progression in multiple sclerosis, and indeed so. But interesting observation came from study from Germany, where in progressive multiple sclerosis, cerebrospinal fluid GFAP was not associated with disability progression, but serum GFAP was associated. Why was that so? Perhaps instability of GFAP, or perhaps GFAP, which is these enfids are closely connected to blood, so GFAP may spill directly into blood and not in cerebrospinal fluid. We would also like to have some information how is the regeneration potential in our patient. And one of the biomarkers which were studied was GAP43, growth-associated protein, which is a marker of synaptic integrity, neuroregeneration, synaptic plasticity. We did, together with the colleagues from Sweden, some study in patients with early multiple sclerosis, and we found that regeneration potential is not reduced in early stages of multiple sclerosis, and also that inflammation, number of lesions in high levels, in high GAP43 were higher compared to if the number of lesions was low. So inflammation may in fact drive regeneration in multiple sclerosis. And this is a study from Sweden a couple of years later, which practically showed similar results. So no reduction in relapsing multiple sclerosis, reduction in progressive, and inverse association with EDSS score and age. So in ideal clinical practice, when seeing a patient, we would be very happy to see how is his or her degeneration potential with biomarkers, whether patient will have relapses, can we predict progression of the disease, and also how is with regeneration potential. And with that, perhaps we'll be able to tailor our treatment better. So far, neurofilament light chain we used in a clinical practice. If we want to monitor disease course and treatment response, then cerebrospinal fluid investigation with lumbar puncture is not feasible because the procedure is invasive. So we have to use some sophisticated technology such as SIMOA in order to try to get information from blood. So we are not yet in the clinic, but we are coming very close to. This is, for example, a big study. Serum neurofilament light chain is again the most studied protein from international group, more than 10,000 samples. And this on a group level, we see how successive blood withdrawals, how neurofilament light chain behaves in untreated patients, patients treated with moderately effective drugs, and patients with high efficacy therapy. So suppression of axonal loss. And there were also some attempts to see how patients will behave in the coming year. So concentration, here it was, it wasn't the concentration that were given, but Z-scores, so deviations from the mean. So higher deviation, more likely that our patient will progress in the coming year. So this is close to clinic. Also, serum GFAP in neuromyelitis optica spectrum disorder. NMO is an autoimmune astrocyte disease. This is a study of efficacy of anti-CD19 agent in abilizumab in patients with NMO, and we see that serum GFAP was higher in patients who were less likely to be relapse-free. So this is a possible biomarker of treatment response in patients with neuromyelitis optica spectrum disorder. This is the only study that was thus far published. This is a work. We will move briefly to some other diseases. Infectious diseases, these are preliminary data we did with colleagues from infectious disease department. Analysis of biomarkers in tick-borne meningoencephalitis and Lyme borreliosis. We checked some of them, and we see how in borreliosis and even more in tick-borne meningoencephalitis, amyloid levels are reduced, indicating amyloidosis in these diseases, perhaps surprising. And as far as marker of axonal loss, they're only increased in patients with tick-borne meningoencephalitis, parenchymal disease. There are some studies from Sweden on the field showing that indeed inflammation-driven amyloidosis is seen in neuroborreliosis, some other diseases. Why is that? We are not sure whether this is because of aberrant APP metabolism, increased deposition of amyloid, as for example, seen in Alzheimer's, or perhaps increased clearance of amyloid beta. And also tau increased, there are some studies showing increased tau levels in patients with infectious diseases. This here explanation is much simple. Tau and neurofilament levels, markers of axonal loss, are mainly seen in encephalitis, where brain is affected, but not in meningitis or borreliosis, where only meninges or nerve roots are affected. So this is explanation, but we can see with the markers whether brain or parenchyma is. And the last topic I would briefly like to touch is pathogenesis. With biomarkers, we can try to get some better insight into pathogenesis of the disease. For example, primary progressive multiple sclerosis, I already told you, this is a progressive disease, poorly responsive to therapy, less inflammation. We know that processes like chronic axonal loss, mitochondrial dysfunction, diffuse microglia activations are something that drives progression in this disease. But some of the groups. For example, this is a study from a group of Mark Diamond from Texas, showed that progressive multiple sclerosis might be secondary tauopathy, and that tau protein could behave like a protein in these diseases, causing something that's called seeding. So aggregates formed, entering the cell, exits the cell, and then served as a template for its own replication. And this would have therapeutic implications. This could have therapeutic implications. And therefore, we also did some in vivo studies together with the colleagues from University of Gothenburg with ultra-sensitive immunoassays against 4 different isoforms of tau protein. We did analysis in patients with different stages of multiple sclerosis, and we indeed find differences between progressive multiple sclerosis compared to CIS and relapsing multiple sclerosis, and also associations with age, EDSS, and disability progression, and EDSS score. I cannot go into detail. This presentation of ours will be presented as a late-breaking abstract at the coming ECTRIMS meeting in Milan. So, to briefly conclude, fluid biomarkers of neurodegeneration help us better understand pathological processes in neuroinflammatory diseases also, as I showed you. And for clinicians, even more importantly, they have potential to be used in clinical practice. Some of them already are, for determination of prognosis, and hopefully very soon in response to treatment in multiple sclerosis and perhaps also neuromyelitis optica spectrum disorders. With that, I would like to thank you for your attention. Thanks my collaborators from MS Center, Laboratory for CSF Diagnostics, and also collaborators from University of Gothenburg. Thank you.